Now it will become very clear. This is the type 1 Mpgn. So what did I tell you? In type 1, what will be there? There will be subendothelial deposits. So on the inner side, what is this? This is the endothelium. Let me show you with another yellow. So this is your endothelium over here, E. Uski just beneath you are having this subendothelial, but this subendothelial is also encroaching and permeating inside the glomerular basement membrane. So it is also causing some kind of a splitting. Understand this point very clearly. So this is the very important, and this deposit, what is it? What nature is of this deposit? It is an immune complex deposit. It is okay. It is an immune complex deposit, very important, and it is having both the components of alternate as well as the classical. So classical minus C1, C4 is also there, along with IgG will also be present. Crystal clear? On the other hand, we are having Mpgn type 2. Over here, the deposit is classically intramembranous, and they are continuous. They are regular ribbon-like. They are not patchy, as we can appreciate over here. So, but remember, the splitting of the basement membrane will be seen in both. So the term splitting of basement membrane is a feature which is seen in both types. Okay, if you have to choose the answer. So this is the classical light microscopic picture. If you see in minimal change disease, the glomerulus is stained with PAS stain, and remember the basement membrane is completely normal. There is no thickening as such, or there is no thickening of the GBM. There is no proliferation of cells over here. So it is completely, the glomerulus is looking normal by light microscopy. Okay, by electron microscopy, what you can appreciate, if you see the foot process, can you see they have become completely flat? Okay, the foot processes which was once present is not there. So there is a flattening of the foot processes, and there is no deposit. You cannot see any kind of deposit. This is the glomerular basement membrane. There is a lamina interna, lamina externa, and lamina densa, as we can appreciate in this particular diagram. Tell me, what is this? This is one glomerulus. Agreed or no? Yes?
Yes, sir.
This is another glomerulus. Okay.
Yes.
Now what I want to ask you in this particular diagram, can you see that one glomerulus is involved, but not completely? A part of the glomerulus is involved. Yes or no? So can we say that this is a segmental change?
Yes.
And what I told you, focal glomerulosclerosis. So there is a protein deposition, along with that extracellular matrix production is there, which under the microscope is looking more pink in color. Yes or no? This is the focal segmental glomerulosclerosis lesion that we see. And the basic stain that we have done over here is the PAS stain, which is highlighting them as well. The segmental sclerosis involving the upper half of both the glomerulus, as we see. This is the light microscopic appearance. Can you see the mesangial proliferation has taken the form of lobules? Yes, can everyone appreciate this? Yes, so this is the lobular architecture in case of type 1 Mpgn. Type 1 Mpgn. They show mesangial cell proliferation with increased mesangial matrix. Okay, there is a increased lobular architecture with infiltration of the leukocytes, endocapillary proliferation, mesangial cell proliferation, extracellular matrix deposition. Today we are going to understand about the nephrotic syndrome. What is nephrotic syndrome, and what are certain disease process which exemplifies the nephrotic syndrome. So nephrotic syndrome, as you will see, it is caused by derangement in the glomerular capillary walls, which results in increased permeability to plasma protein. So what are the manifestations of this syndrome? There is a massive proteinuria with a daily loss of 3.5 grams or more of protein in urine. Okay, very, very important. So there is a massive proteinuria with a loss of 3.5 grams or more of protein. Hypoalbuminemia with plasma albumin levels less than 3 grams per deciliter. There is a generalized edema or anasarca. Along with that, there is hyperlipidemia and lipiduria. Now, heavy proteinuria, it is going to deplete the serum albumin level at a rate beyond the compensatory capacity of the liver, and this is going to result in hypoalbuminemia. So you should be able to answer that what is the cause of hypoalbuminemia. Because of heavy proteinuria, the rate of depletion of serum albumin being more than the compensatory synthetic capacity of the liver, that results in hypoalbuminemia. Also, there is an increased renal catabolism of the filtered albumin, which also contributes to the hypoalbuminemia. Now, the generalized edema that we see, it is a direct consequence of decreased intravascular colloid osmotic pressure. So, as you already know that if we see that this is our blood vessel, so there are two forces. One force is acting outward, which is the hydrostatic pressure. Another force is acting inward, which is called as the colloid osmotic pressure. Now, this colloid osmotic pressure, it is because of the plasma proteins which are present, okay, in our blood. Now, if the plasma proteins, that is the albumin, when it is lost, okay, as it is lost, so what is going to happen? The colloid osmotic pressure will also fall, and as a result an excessive amount of fluid will come out of the blood into the tissue spaces. Okay, is this point very clear to everyone? So this is basically the cause of generalized edema in case of nephrotic syndrome, because of a decrease in the intravascular colloid osmotic pressure. Not only that, there is also sodium as well as water retention, which will further aggravate the edema. Now this seems to be, this sodium and water retention occurs to be because of several factors, including compensatory excessive secretion of aldosterone. Now if you look at this kind of edema that takes place, if you see, this edema is characteristically soft and pitting. That means if you press it, it is going to pit. Okay, and it is most marked. So renal edema, okay, it is most marked in the periorbital region and as well as in the dependent portions of the body. If it is severe, it might also lead to pleural effusions as well as ascites. So this is the basic symptoms of nephrotic syndrome. It is not any kind of a disease. It is just a syndrome with 4 important components. And what is the cause of these components? We have also read about that. Now, one very important thing is that the largest proportion of protein which is lost in urine is albumin. Okay, but some amount of globulins are also excreted in some disease. Now, can you tell me why albumins are the largest proportion of protein which are lost in nephrotic syndrome? Yes, what will be your reason?
Smaller size.
Yes, so it is actually the first protein to be lost in the urine. Okay, always remember this point very importantly. Okay, now the very important thing is the kind of proteinuria. If you see, the ratio of the low to high molecular weight protein in the urine in various cases is a manifestation of selectivity of proteinuria. That means if more amount of albumin is lost, then we will say it is a highly selective proteinuria. If apart from albumin, other kind of plasma proteins are also lost, then we will say it is a non-selective kind of proteinuria. Okay. So a highly selective proteinuria, as I just mentioned, it is mostly consisting of low molecular weight proteins, that is the albumin, which is around 70 kilodalton in size. Whereas poorly selective proteinuria will be consisting of higher molecular weight globulins in addition to the albumin. Okay. Now remember, why is there hyperlipidemia and nephrotic syndrome? So the answer is lying over here. So the genesis of hyperlipidemia is quite complex, but most patients that we see in nephrotic syndrome have an increased or altered lipid profile with an excessive level of blood cholesterol, triglyceride, VLDL, LDL, okay, lipoprotein A as well as apoprotein. And there is a decrease in the HDL or high density lipoprotein concentration. So the good lipid, that is the HDL, falls, whereas all the bad lipid, that is the LDL, VLDL, triglyceride, cholesterol, all of them, they increase in amount. Okay. Now these defects seems to be due to combination of increased synthesis of lipoproteins in the liver. Okay, so why it is happening? Very important. There is then combination of an increased synthesis of lipoproteins in the liver. Okay, abnormal transport of circulating lipid particles and decreased lipid catabolism. These are the important causes of hyperlipidemia in case of nephrotic syndrome. So an excessive synthesis of lipoproteins in the liver, abnormal transport of the circulating lipid particles, and decreased lipid catabolism. So all these are 3 important causes of hyperlipidemia in case of nephrotic syndrome. Now lipiduria, now if the amount of lipid in the circulation is high, so that will lead to what is called as a lipiduria. There will be loss of lipid in urine. Okay, so lipiduria follows hyperlipidemia as lipoproteins also leak across the glomerular capillary wall. Okay, so the lipid appears in the urine as a free fat or as oval fat bodies representing lipoproteins which are resorbed by the tubular epithelial cells and then which are also shed along with the injured tubular epithelial cell when they die. Okay, when they die. Okay. Now, nephrotic patients, if you see, they are quite vulnerable even to infections. Can you tell me why? Because immunoglobulins, which are one kind of plasma protein, in fact, it is a kind of a globulin. It is also lost in urine. So, there is a decreased immunity. Especially, you will have a staphylococcal as well as pneumococcal infection. Now, thrombotic and thromboembolic complications are also common in case of nephrotic syndrome. Why? It occurs due in part to loss of endogenous anticoagulants in the urine. So, thrombotic and thromboembolic complications are very common in nephrotic syndrome. Why? Because of loss of endogenous anticoagulant, like the antithrombin 3 is also lost. It is all a part of plasma protein. Okay, because of loss of that only, there is thrombotic and thromboembolic complications as well. Now, renal vein thrombosis, once thought to be a cause of nephrotic syndrome, is most often a consequence of this hypercoagulable state. So, whatever thrombotic complications, it occurs because of this, and this renal vein thrombosis is most commonly seen in membranous nephropathy, which is one type of nephrotic syndrome. Okay, one of the manifestations of nephrotic syndrome. Okay. So, the incidence of several causes of nephrotic syndrome can vary according to the age and geography. In children younger than 17 years, for example, nephrotic syndrome is almost always caused because of primary lesion of the kidney. That means only there will be some abnormality in the kidney. There is no secondary disorder. That means nephrotic syndrome does not occur secondary to any kind of disorder. But in case of adults, if you see in contrast, nephrotic syndrome is often associated with a systemic disease. So, very important point. The most important systemic causes of nephrotic syndrome, that means in case of adults, it is diabetes mellitus, amyloidosis and SLE. The most important of the primary glomerular lesions, that means in case of children, is minimal change disease, membranous nephropathy and FSGS. Okay, very, very important point. Okay, the first, that means the minimal change disease, if you see, it is very common in children. So, these are primary glomerular nephropathy condition wherein only the kidney will be involved, and among them, if you see, MCD is one condition which is a primary glomerular lesion, okay, which is just a primary kidney disease, is most common in children. MCD, that is a minimal change disease. Whereas if you see the membranous nephropathy, if you see, it is a nephrotic and a primary nephrotic condition which is most common in older adults. Whereas focal segmental glomerulosclerosis can occur at all ages. These points are very important. You have to understand first thing that usually in younger patients less than 17 years, you have primary nephrotic syndrome, whereas in case of adults, mostly it is secondary to systemic disease. So, the most common systemic disease is the diabetes, amyloidosis, SLE. So, already we have read in details about diabetes mellitus, amyloidosis and SLE. We will read when we will read the chapter on immune system. Okay. So, over there we will discuss what are the signs, symptoms of nephrotic syndrome in those patients. Whereas in this particular chapter, we will deal mainly with the minimal change disease, membranous nephropathy and FSGS. All these three conditions are primary glomerular lesions. Means these conditions will present with nephrotic syndrome and there will be no other systemic sign symptom. That means only the kidney is affected. Out of this, the MCD is most common in children, membranous nephropathy in older adults, whereas FSGS occurs in all ages. So, this point becomes very, very important. Okay. So, there are other less common causes of nephrotic syndrome, for example, membranoproliferative glomerulonephritis as well as IgA nephropathy. Okay. So, the causes of nephrotic syndrome, I am not repeating again, you can go through this chart. So, it can be primary glomerular disease, these are the causes, and you can have systemic disease, which are the causes of nephrotic syndrome, which I have already discussed in details. So first, very importantly, we will start with membranous nephropathy. Now, as you already know that this type is seen in older adults, that we see that is a membranous nephropathy which presents as a nephrotic syndrome. So membranous nephropathy is characterized by a diffuse thickening of the glomerular capillary wall because of accumulation of deposits containing immunoglobulins along the subepithelial side of the basement membrane. So already in the pathogenesis of glomerular injury, I hope you remember I have discussed these points, okay, basic points, that where, in which conditions, okay, where the deposits will be. Approximately 75% cases of membranous nephropathy, if you see, they are primary in nature. So you know what is the meaning of primary, that means only the kidney will be involved. Whereas the rest 25% cases of membranous nephropathy can occur secondary to some kind of systemic disease, and they can have any identifiable cause, and hence they are also referred to as secondary membranous nephropathy. So the most notable associations of secondary, or where an etiology is present, is secondary to certain kinds of drugs. Okay. Then there might be secondary or underlying malignant tumors, for example carcinomas of lung, colon. Okay. Then secondary to SLE, around 10 to 15% of glomerular nephritis and SLE, it is of membranous variety, but the majority varieties, if I am not mistaken, is your subendothelial variety. Or it might be secondary to certain kind of infections, especially chronic hepatitis B and C infections, or other autoimmune disorders such as autoimmune thyroiditis. Okay. So these are the causes of secondary membranous nephropathy. So let us try and understand what is the pathogenesis. As I told, in this condition there is a subepithelial deposit of your what should I say, of immunoglobulins, that we have already discussed. Okay. So basically, membranous nephropathy is a form of chronic immune complex mediated disease. So it is a form of a chronic immune complex mediated. Now you tell me, which type of hypersensitivity reaction will be this? Yes, we have already read about hypersensitivity reaction.
Type 3.
Very good. This will be type 3 because it is immune complex mediated. Okay, in the secondary variety, the antigenous, as I told you, the secondary variety is the one where there is some etiological agent that is known, and over there the antigens may be endogenous or exogenous in nature. Okay. Now membranous nephropathy in case of SLE, if you see, is associated with deposition of complexes, okay, which is containing the antigen in the form of self-nuclear proteins. The body nuclear proteins or DNA proteins, they are itself acting as what should I say, a source of proteins. Okay. And autoantibodies. So the autoantibodies in SLE react with the self-nuclear proteins and form certain immune complex. Okay. Other antigens can include exogenous antigens, that means those derived from hepatitis B virus or from other agents, microbial agents like Treponema pallidum. So in case of membranous, the antigen source means in exogenous variety of the membranous, in the systemic variety of the membranous nephropathy, if you see, the antigens can be exogenous or endogenous. Endogenous as in case of SLE, and exogenous as in case of microbial infection. But the primary variety of membranous nephropathy, it is basically an autoimmune condition which is caused in most cases by antibodies to a renal autoantigen. So first of all, we have to understand, in secondary causes, the antigens were either some microbial agents or certain self-antigens in our body. But in case of primary variety of membranous nephropathy, you have to understand that it is an autoimmune disorder wherein the antibodies are formed against certain antigens which are specific in the kidney, which are found in the kidney itself. So that is why they are primary. They are not secondary to any other thing. There is primarily formation of autoantibodies against renal antigen. So very, very important. Now there has been a discovery that this particular antigen in the kidney is the PLA2R receptor, that is the M-type phospholipase A2 receptor, is acting as an antigen that underlies 60 to 70% cases of human membranous nephropathy. Human membranous nephropathy. Okay. Okay. Now autoantibodies, they bind to this PLA2 receptor, okay, or this phospholipase A2 receptor, which is a membrane protein which is present at the basal surface of the glomerular epithelial cell. Okay, very, very important. So which kind of epithelial cell? It is the visceral variety. And once antigen antibody will combine with each other, that is going to lead to complement activation. and shedding of this immune complex or immune aggregates, okay, from the cell surface to form the characteristic deposits of immune complex along the subepithelial aspect of the basement membrane. So this becomes very, very important. So over here you have to understand the antigen in case of the primary variety is the play to phospholipase A2 receptor is the main antigen. Okay, very importantly, and once the complex complement activation is there, the immune complex will form and deposit along the subepithelial aspect of the basement membrane. Now this is the first and most common variety of antigen implicated in case of membranous variety of nephritic syndrome. Nephrotic syndrome. Now less commonly the target antigen is thrombospondin type 1 domain containing 7A, THS D7A. This might also act as an antigen in few cases, or some other antigen is your CD10. Okay, can also be another antigen. So these are the other antigens which might be implicated, especially in case of neonatal membranous nephropathy. Now, how does the glomerular capillary wall become leaky in membranous nephropathy? So what is the cause that the glomerular capillary wall will become leaky? Let us try and understand. So how does the, so basically remember, there is a paucity as compared to your nephritic syndrome, as in case of acute streptococcal glomerulonephritis. If you compare in case of membranous nephropathy, there is a reduced cellularity. There is a paucity of the inflammatory cells in the glomerulus. The complement C5bC9, which is the membrane attack complex, has a very important role. So it is hypothesized that this C5bC9 complex will activate the glomerular epithelial as well as the mesangial cells. Okay, and they will induce them to liberate certain proteases and oxidants, which will cause the capillary wall injury and increase the protein leakage. So the glomerular capillary wall injury is basically mediated by the proteases and oxidants which are released by activated glomerular epithelial and mesangial cells as a result of complement activation secondary to antigen antibody formation. Okay. Now a subclass of immunoglobulin, that is G, that is called as IgG4, okay, is a very poor activator of the classical complement active, is a principal immunoglobulin deposited in most cases of membranous nephropathy. So remember that IgG4, it is not the same like the other classes of IgG. It is a very poor activator of the classical complement pathway, and it is the principal immunoglobulin which is deposited in most cases of membranous nephropathy. So this is the very important pathogenesis of membranous glomerulonephritis. So by light microscopy, if you see the glomerulus, it will appear either normal in the early stages, okay, of the disease, or they will exhibit uniform diffuse thickening of the glomerular capillary wall. The glomerular capillary wall itself will become diffusely thickened. If you carry out an electron microscopy, if you see under the electron microscope, the thickening, if you see, it is caused by irregular electron dense deposits which is containing immune complex. So by electron microscopy you can demonstrate irregular electron dense deposits. Okay, and this is present between the basement membrane and the overlying epithelial cells with effacement of the podocyte foot process. So this podocyte foot process has been effaced. This term becomes very, very important. And the immune complex is present between the glomerular basement membrane and the visceral epithelial cell. So it becomes a subepithelial deposit. Now basement membrane material is laid down between these deposits. So in between this electron dense immune complex deposits, you will always see basement membrane material which is deposited, which appears as a spike. So if, for example, over here this is the electron dense deposit, basement membrane deposit will also be kept like this. So it will look basically like irregular spikes protruding from the glomerular basement membrane. Okay, and these spikes that we are watching, they are best demonstrated by the silver stain. Okay, remember, so the silver stain is going to color only the basement membrane material, but it is not going to color the electron dense deposits. Okay, by immunofluorescence, as I told you, all types will be granular deposits will be there. Okay, and they are containing both the immunoglobulins as well as the complement. So if we can see, we can appreciate this particular diagram. If you see over here, Okay, so this is the silver methamine chain. So as you can appreciate, there's a diffuse thickening. So this capillary wall has been diffusely thickened. Okay, and some of them, if you see this, I don't know if you can appreciate, if you just zoom your phone and if you see around the glomerular basement membrane, I'm just going to make it more appreciable. This is the GBM. If you see, there is a star shaped spiky deposit over here. Okay, this is very important. These are the prominent spikes of the silver staining matrix. This is the basement membrane material, which is actually protruding from the glomerular basement membrane lamina densa towards the urinary space, towards the outer side in the Bowman's capsule. Okay, very, very important. So there is a prominent diffuse thickening of the capillary wall. Along with that, you will see characteristic spikes of silver staining material, basement membrane material, that becomes very important in this particular case. Now, if you do basically electron microscopy, you will see, can you appreciate this characteristic electron dense deposit? Okay, this is the electron dense deposit. Now, if you see over here, the foot processes have already been effaced. There is an effacement of the foot process. If you see this, the foot process, it is completely flat over here. It is completely flat foot process. Usually the foot processes were thrown like this. Okay, but over here, if you see, it is flat. So you will see the electron dense deposits along the epithelial side of the basement membrane. This is your basic GBM, glomerular basement membrane. Over here, this is your place where the deposit is there, and there is an effacement of the foot processes overlying the deposits. So this is the basic immunofluorescence study. As we can appreciate, we have the granular pattern of deposit as we can appreciate over here. Okay, and very importantly, you can see the granular immunofluorescent deposits of immunoglobulin along the glomerular basement membrane. If you can appreciate, this is your thickened, the glomerular basement membrane is quite thickened. Okay, and very importantly, if you see, this is the visceral epithelium. So just beneath it, you are having the subepithelial deposits. Beneath the epithelium, that is the subepithelial deposits. And if you see, there is an effacement of the foot process. So normally over here, they are thrown into folds like this. But over here, the foot processes are not seen. They are actually effaced, or they are flattened foot process, as we can appreciate from this diagram. Okay. Now, what are the clinical features that we are going to appreciate in case of, membranous nephropathy? Let us try and understand what are the clinical features. So they usually present with a very gradual onset of nephrotic syndrome, okay, or in 15% of the patients with non-nephrotic proteinuria. So all the proteinuria is there. So always remember one thing, in majority of the disease that we are reading. So for example, in membranous nephropathy, okay, majority of the patient will have nephrotic syndrome. That means they will have nephrotic range proteinuria. But in some of the patients, if you see, in around few patients, 15% patients, they might show non-nephrotic proteinuria, wherein the proteinuria is not that much, is less than 3.5 gram per day. Also, signs, symptoms of nephritic syndrome might be present in some cases. So the cases are not very much separate from each other. So these cases might also show mild hematuria, mild hypertension might be present in approximately 15 to 35% of the patients. Okay. Now, before you give a diagnosis of membranous, it is very necessary for any patient to rule out any kind of secondary cause. Okay, very important. You have to rule out any secondary cause, because the treatment of the underlying condition, the malignant neoplasm infection or SLE, or discontinuance of any offending drug can reverse the process. So if you know that the particular membranous nephropathy is because of certain cause, if you identify the cause, then you can reverse the process. Okay, usually the process is indolent. In contrast to minimal change disease, which is the next topic of discussion, the proteinuria over here is non-selective. That means along with albumin, other types of plasma proteins are also lost. And very importantly, this variety does not respond, membranous nephropathy does not respond to corticosteroid therapy. Complete or partial remission may be seen in only up to 40% of the patients. Okay. The progression is often associated with increased fibrosis or sclerosis of the glomerulus, a rising serum creatinine level reflecting the renal insufficiency, and development of hypertension. So if there is any kind of a sclerosis, rising urea creat, renal insufficiency, development of hypertension, then these are poor signs. Okay. So although proteinuria persists for more than 60% patients, only about 10% will die or progress to renal failure within 10 years, and not more than 40% will eventually develop chronic kidney disease or end-stage renal disease. Now the disease can recur in up to 40% of the patients who have undergone transplantation for end-stage renal disease. Okay, very, very important. Now, which are the useful biomarkers of the disease activity? Antibodies to the phospholipase A2 receptor and THSD7A. Okay, these are useful biomarkers of the disease activity, and therefore they are helping in diagnosis as well as management of membranous nephropathy. So with this, we have completed the flagship nephrotic syndrome, which is usually seen in older adults, that is the membranous nephropathy. Anyone is having any kind of doubt with regards to this part? Yes? Is it very clear to everyone? Okay. So now we will go into the next very important topic, that is the minimal change disease. Now try to understand, at this point of time maybe you are thinking that kidney is little bit difficult. There are many things to understand in the kidney, but remember, this will again be there in your medicine. This will again be there in your pediatrics. Okay, so this is very, very important, and lots of MCQs they are coming based on the kidney. Okay, so very importantly, the next very important nephrotic syndrome, and especially the most common presentation of nephrotic syndrome in case of children, is your minimal change disease. It comes as a long answer question in medicine, in pathology, as well as in pediatrics. Okay, in all these conditions this will come as a long answer question, minimal change disease. So it is a very benign disorder. Okay, it's a very benign disorder characterized by effacement. There is a diffuse effacement of the foot processes of the visceral epithelial cells, that is the podocytes. Okay, and remember, whatever effacement is there, you cannot detect any of these changes under light microscopy. So whatever problem is there, you cannot appreciate anything under light microscopy. Only the effacement of the foot process can be appreciated under electron microscopy. In the glomerulus will appear completely normal by light microscopy. So this is a very classical and an important finding. Okay, it is the most frequent cause, that is the MCD, the minimal change disease, is the most frequent cause of nephrotic syndrome in case of children, but it is far less common in case of adults. The peak incidence is between 2 and 6 years of age, and the disease sometimes follow respiratory infection or a routine prophylactic immunization. So what is the pathogenesis of this minimal change disease? So although the absence of immune deposits in the glomerulus will exclude the immune complex mediated injury, several features of the disease will point to an immunological basis. So very important, although we do not find any kind of immune deposits, okay, over here, but there are lots of immune etiology over here. So there is a clinical association of minimal change disease with respiratory infections as well as with prophylactic immunization. So whenever there is a prophylactic immunization or respiratory infection, there is a clinical association with it. Now very importantly, the first line of treatment for minimal change disease is steroids. The patient is responding to corticosteroids and other immunosuppressive therapy. So that is also pointing towards an immune origin. The association with other allergic or atopic disorders like eczema and rhinitis in such patients. The increased prevalence of certain HLA haplotypes in cases associated with atopy. The increased incidence of MCD in patients with Hodgkin's lymphoma, in which there is a defect in the T cell mediated immunity. So the current hypothesis or belief is that minimal change disease is involving some form of immune dysfunction that results in the elaboration of factors that is going to damage the visceral epithelial cells, causing effacement of the foot processes, and ultimately it will lead to proteinuria. This is the basic hypothesis as of this point of time. So the ultrastructural changes, okay, they point to a primary visceral epithelial injury that is called as podocytopathy. Okay, so basically, very importantly, there is a loss of glomerular polyanions. Okay, so that negative charge is the polyanions is basically lost. Okay, thus defects in the charge barrier may contribute to the proteinuria. Okay, so what happens that usually the what should I say, the plasma proteins, they are negatively charged. So when they come in contact with the glomerular capillary wall, which is again containing negatively charged polyanions, okay, the sialoproteins, so they are repelled and therefore they are not filtered out. But over here there is a loss of the charge, okay, there is a defects in the charge, okay, there is actually loss of the polyanions on the negative charge. As a result, the repulsive forces are gone and therefore the chance of permeability of the plasma proteins increases. Characteristically, if you see in minimal change disease, that is completely normal by light microscopic study. Okay. By electron microscopy, if you see the glomerular basement membrane, it appears completely normal and there is no electron dense material which is deposited. So you cannot see any electron dense material, either subendothelial, sub, nothing. As in case of the membranous variety, we had seen the subepithelial deposits. Over here, no deposits is seen by either electron microscopy or by immunofluorescence. The principal lesion of MCD, as I told you, uniform and diffuse effacement of the foot processes, very, very important. Okay, and there is a loss of the intervening slit diaphragms which are formed by the nephrin proteins along with the podocin, actin components as well. Okay. So this change that we see, it represents a simplification of the epithelial cell architecture with flattening, retraction and swelling of the foot processes. Now the foot process effacement is also present in other kind of proteinuric states. For example, in membranous glomerulopathy, just right now we read that sometimes some amount of effacement of the foot process is also present in that. So it is not a very specific finding for minimal change disease, but a foot process effacement along with light microscopic findings which are completely normal, okay, that is basically in favor of minimal change disease. So the foot process effacement is also present in other, I have already read that, okay. So basically remember that foot process effacement is already present in other proteinuric states like the membranous glomerulopathy as well as the diabetic nephropathy, but remember, only when the effacement is present along with a normal glomerulus by light microscopy that the diagnosis of MCD or minimal change disease will be made. Okay. So the visceral epithelial cells, if you see the changes, that is the foot process effacement is completely reversible if you give corticosteroid therapy. Okay, concomitant with remission of proteinuria. So after you give this, okay, there will be a very nice response to therapy. Now the cells of the proximal convoluted tubules, they become laden with lipid and protein, reflecting tubular reabsorption of lipoproteins which is passing through the diseased glomerulus. Okay, and that is the reason, because the tubules are filled up with lipids, okay, which had already filtered through the defective glomerular capillary wall. That is why this condition is also called as lipoid nephrosis. By immunofluorescence, no immunoglobulin or complement deposits are seen in this condition. So despite the massive proteinuria, the renal function in these patients, children, they remain good. And there is commonly no hypertension or hematuria as it was seen in few patients of membranous glomerulonephritis. The proteinuria, very, very important. Over here, the proteinuria is highly selective. In membranous glomerulonephritis, it was non-selective. So over here, the predominant protein that was being lost is only albumin. And the characteristic feature of this minimal change disease is a dramatic response to corticosteroid, which was not there in case of membranous glomerulonephritis. So most children, more than 90% with minimal change disease, they will respond rapidly to this treatment, to the corticosteroid. The long-term prognosis of these patients is excellent, and even steroid-dependent disease usually resolves when children will reach puberty. So those children who are dependent on steroids, okay, so up till puberty, this disease will go, okay. So the long-term prognosis of this condition is quite excellent. So minimal change disease in adults, okay, are present, and when present, they are associated with Hodgkin's lymphoma and less frequently other lymphomas and leukemia as well. In addition, secondary minimal change disease may follow NSAID therapy as well, usually in association with acute interstitial nephritis. It might also take place. So this is the classical light microscopic picture if you see in minimal change disease. The glomerulus is stained with PAS stain, and remember the basement membrane is completely normal. There is no thickening as such, or there is no thickening of the GBM. There is no proliferation of cells over here. So it is completely, the glomerulus is looking normal by light microscopy. Okay, by electron microscopy, what you can appreciate, if you see the foot process, can you see they have become completely flat? Okay, the foot processes which was once present is not there. So there is a flattening of the foot processes and there is no deposit. You cannot see any kind of deposit. This is the glomerular basement membrane. There is a lamina interna, lamina externa and lamina densa, as we can appreciate in this particular diagram. So today's topic of discussion, today we are going to continue the nephrotic syndrome and we are going to see certain special cases. So focal segmental glomerulosclerosis. So you tell me which kind of syndrome it is, whether it is nephrotic or nephritic syndrome. Yes, it is nephrotic syndrome only. Okay, one type of nephrotic, whether it is seen in adults or it is seen in children. Very good, fantastic. It is seen classically in case of adults. Okay, so these are certain special forms of glomerular nephritis, that is nephrotic syndrome cases that we will see. Now from now on, whatever kind of nephrotic syndrome or nephritic syndrome that or whatever conditions we are going to read today, they might not be completely a nephrotic syndrome. Understand? Means, so for example, some patients might have subnephrotic proteinuria. So what is nephrotic range proteinuria? How much was the nephrotic range? It was more than 3.5 grams per day. Okay, so this was the nephrotic range. Some people might have mild hypertension also, which should not be present in case of a nephrotic syndrome. Which should not be present in case of a nephrotic syndrome. Is this point making some sense? So today, whatever kind of prototype disease that we had read in the previous lectures, they were for nephritic and nephrotic. Today we are going to read certain important conditions, okay, wherein we are going to understand, okay, wherein we are going to understand in details about this particular topic, that is the FSGS. Okay, so focal segmental glomerulosclerosis. So this is the topic of discussion that we will start today. It is the most common cause of nephrotic syndrome in case of adults. Okay, in most common cause of nephrotic syndrome in case of adults. So it is not the membranous. It is the primary FSGS is the most common cause of nephrotic syndrome in adults. What is the most common cause of nephrotic syndrome in case of children? Very good. So the answer will be MCD, that is the minimal change disease. It is considered to be a primary disorder of podocyte. Just like the minimal change disease, here also the major dysfunction is there in case of podocyte. Now what do I mean by primary? When I am saying that this is a primary FSGS, what do I mean by primary? Primary means? Very good. This is just going to affect the kidney. It is not secondary to any kind of systemic disorder. So as the name suggests, it is a focal segmental glomerulosclerosis. So what do you mean by focal? What is the meaning of focal? I have already explained these terms in the first basic lecture. What is the meaning of focal? Yes? Affecting what? No, it is not a particular point. Focal means what? If for example there are 100 glomerulus, so for example focally approximately 4-5 in one focus, 4-5 in other focus, but not all the glomerulus in the kidney will be involved. So it is a focal change. Some parts of the kidney, that change is going to take. That is the meaning of focal. So don't make a mistake over there. Lots of MCQs are based on just this focal and segmental. So the lesion is characterized by sclerosis. Sclerosis meaning what? It means fibrosis of some, but not all the glomerulus. That means out of 100 glomerulus, if it is there, around 30-40 glomerulus will be involved. So thus the change is focal in nature. And suppose whichever glomerulus is involved, in that also the entire glomerulus is not involved. Only a part or a portion of a particular or individual glomerulus will be involved. That means this change is segmental in nature. Do you understand what is the meaning of segmental? Only a part of the glomerulus is involved. So we call it as FSGS. So first this concept should be very clear. Why it is called FSGS? Focal segmental glomerulosclerosis. So there is fibrosis of some of the glomerulus and the involved glomerulus is only involved by part, not total. Okay, clear to everyone? Okay. So FSGS is frequently manifest clinically by acute or subacute onset of nephrotic syndrome, and this is all right, nephrotic, or sometimes there might be non-nephrotic proteinuria as well. So now you understood why I was not teaching these topics together with nephrotic or nephritis, because they have majority symptoms of some syndrome, but not completely those symptoms will be there. Okay, so basically this is a nephrotic syndrome in adults which may or may not have nephrotic range proteinuria. Also, if you see hypertension, microscopic hematuria and some degree of azotemia are commonly present when the disease is first clinically recognized. Okay, is this point very clear? Now all these features, they are feature of, is it a feature of nephrotic syndrome? Hypertension, hematuria or azotemia, is it a feature of nephrotic syndrome? This is a feature of nephritic syndrome, but some of the patients might show these signs, symptoms as well. Is this point crystal clear to everyone? Okay. Now what is very important over here, the classification and the types. A lot of number and marks are there for this classification and types, and it is one of the most difficult parts to understand. If you understand in the first time that if I am teaching you, then really you are very intelligent. So FSGS can occur in many settings. Firstly, it can occur as a primary disease, that is as an idiopathic focal segmental glomerulosclerosis. That means where a known cause is not there, just the kidney is affected, no secondary condition is known. Okay. In association with other conditions, it can occur. For example, it can occur in association with HIV, wherein we call it as HIV associated nephropathy, or with heroin addiction, or secondary to sickle cell disease. And for example, it might occur in case of morbid obese persons as well. Or it can occur as a secondary event. It might occur as a secondary event reflecting scarring of previously active necrotizing lesions. It can occur as a secondary event reflecting scarring of previously active necrotizing lesions, as in case of focal glomerulonephritis, example IgA nephropathy. So some other kind of nephropathy was present, that is IgA nephropathy, which is basically a focal glomerulonephritis. Okay, so in those active necrotizing lesions, okay, they in a later stage developed scarring, and secondarily to such active necrotizing lesions they developed FSGS. Is this point very clear? Now the number 4th point is as a component of the adaptive response to local loss of renal tissue. So whenever there is a excessive amount of loss of renal tissue, for example, there is congenital anomalies, okay, for example unilateral renal agenesis or renal dysplasia, okay, or for example there is acquired causes like reflux nephropathy is one acquired cause, or in advanced stages of other renal disorders like hypertensive nephropathy. So remember, whenever there is a loss of renal tissue, okay, so whatever remaining normal glomerulus is there, they will undergo some kind of compensatory change. They will work more, but in the process initially they will manage the kidney properly, but in the later stage they will undergo sclerosis in the form of FSGS. Remember this point very importantly. Whenever there is a loss of renal tissue secondary to any congenital, acquired or hypertensive nephropathy. Fifthly, the FSGS can occur in inherited forms of nephrotic syndrome, wherein the disease may be caused by mutation in the genes that are encoding the proteins of the slit diaphragm. Now, do you remember these proteins? Podosins, alpha-actinin, TRPC6, all these proteins have been discussed, and the pathology and anatomy of the slit diaphragm has been shown before. Okay. Okay. So idiopathic FSGS, if you see, they are accounting for 10 to 35%. Now idiopathic means now we are first talking about this primary FSGS. Okay, so we are first talking about the primary FSGS. It is accounting for 10 to 35% cases of nephrotic syndrome in children and adults. So in children only 10% are having this idiopathic FSGS, and in adults 35% of adults are having FSGS. Now FSGS, if you see, has increased in incidence and is now the most common cause of nephrotic syndrome in adults. So the answer for nephrotic syndrome in adults, if the one important question, the option you have to choose, it should be what? FSGS. It should not be membranous glomerulonephritis. Okay. Now the clinical signs differs. Now how is FSGS different from MCD? Let us see. Over here, the incidence of nephritic-like syndrome is much higher. In minimal change disease, such signs symptoms of nephritic syndrome is not there, like hematuria, azotemia with reduced GFR, hypertension. These features are not there. The proteinuria in case of MCD, if you remember, was selective. Selective means which protein was lost in urine. Albumin was the one which was highly lost in case of MCD, but over here the proteinuria is more non-selective. Now if you remember yesterday I told you in MCD, if you see, okay, in MCD minimal change disease, if you see, they had a very good and excellent response to corticosteroid therapy, okay, very good response to corticosteroid therapy, but over here they have a very poor response to corticosteroid therapy, okay. Number 4, there is a progression to chronic kidney disease, that is CKD, okay, with at least 50% developing end stage renal failure within 10 years. So the rate of progression to CKD is very, very high. Is this point very clear about the idiopathic FSGS and how they are different from MCD? Okay. Now, very importantly, the other type, that is the inherited form, which was the 5th important type, okay, of FSGS. I will come to the in between. Now over here there are certain MCQs. One of the important relevant genes of the slit diaphragm is the nephrin, which is encoded by a gene called as NPHS1 present in chromosome number 19. Now nephrin, if you remember, it is a key component of the slit diaphragm, if you remember the diagram, and it is controlling the glomerular permeability. So several mutations of the NPHS genes have been identified that will give rise to congenital nephrotic syndrome of Finnish type, F-I-N-N-I-S-H, Finnish type, producing a glomerulopathy which is like the MCD type with extensive effacement of the foot process. This is asked as an MCQ. Okay, and this is also autosomal recessive in nature. The other distinctive pattern over here of inherited form of FSGS is a distinctive pattern of autosomal recessive FSGS resulting from mutation. Over here will be NPHS2. Over here was NPHS1 gene. Over here is NPHS2 gene. Now what does this gene encode? It is encoding another protein of the slit diaphragm that we had seen, that is called as podosin, present in chromosome number 1. It is also present in a component of the filtration barrier of the slit diaphragm. So mutations in this gene will result in a syndrome of steroid resistant nephrotic syndrome of childhood onset. This is the second important, and these are the two most important inherited forms of FSGS. So you have to remember NPHS1, nephrin, chromosome 19, congenital nephrotic syndrome of Finnish type. The second thing you have to remember, and both of these conditions are autosomal recessive. The other one, NPHS2, chromosome 1, podosin, syndrome of steroid resistant nephrotic syndrome. You have to remember these two very importantly. Now there can be other kinds of mutations, okay. Some of the autosomal dominant variety of FSGS, they have mutations in the gene encoding the podocyte actin binding protein alpha actinin 4. So this protein is also there in the slit diaphragm, so they might give rise to autosomal dominant FSGS, which is gradual in onset, but they have a very high rate of progression to renal insufficiency. Mutations in other genes encoding the TRPC6, which is also basically one of the slit diaphragm proteins, has been seen in adult onset FSGS. And remember that yes, this is also one other mutation that we see, okay. Then we have, there are two sequence variants, okay. G1, G2 risk alleles is there, okay, in apolipoprotein L1 gene on chromosome 22, which has also been associated with an increased risk of FSGS and renal failure in patients of African descent. So this one other mutation in apolipoprotein 1 gene in chromosome 22 have also been associated with FSGS. So this is also coming under the inherited varieties, okay. Then the renal ablation 1, the renal ablation, or in those forms where there is a loss of tissue. So remember, a loss of FSGS can occur as a complication of both glomerular as well as non-glomerular diseases, resulting in a decrease in the amount of functional renal tissue. So there can be many causes like unilateral agenesis, like in congenital cases, or reflux nephropathy might be there. So by any means there is a loss of renal tissue. So when there is a loss of renal tissue, it is seen that there is a progressive glomerulosclerosis and renal failure. That means they have FSGS in the normal remaining glomerulus. Okay, and very important, this FSGS is basically occurring in the unaffected glomerulus of the diseased kidney. So for example, if this is the kidney, this glomerulus are healthy, only these glomerulus are bad. So once this entire tissue is lost, you will see that this remaining portion of the glomerulus will undergo FSGS, and this remaining portion of the glomerulus is basically the unaffected part of the kidney. So over here there is a compensatory hypertrophy of the remaining glomerulus. Okay, and this compensatory hypertrophy will initially maintain the renal function test, but at a point of time they will fail, and there will be development of proteinuria, and segmental glomerulosclerosis or FSGS is going to develop, and eventually total glomerular sclerosis and uremia will develop. Okay, the glomerular hypertrophy leads to hemodynamic changes. So there is alteration in the systemic blood flow, filtration, transcapillary pressure, and ultimately systemic hypertension or nephrotic syndrome like condition is going to develop. So this is how loss of renal tissue leads to classically development of FSGS. Okay. Now, in any of these causes, if we see that what are the sequence of events that leads to sclerosis in the setting. Okay, in this setting means in the setting of loss of renal tissue when is there, then how they lead to sclerosis. So you have to understand that whenever there is a loss of renal tissue, and in this setting there is an excessive endothelial and visceral epithelial cell injury. Visceral epithelial loss will lead to segments of basement membrane which is having no food process. The food process is lost. Okay, consequent there will be an increased glomerular permeability to the plasma proteins, and accumulation of such proteins will finally takes place in the mesangial matrix. Okay, so whatever damage occurs to the epithelial, visceral epithelial cell or to the glomerular basement membrane will ultimately lead to the accumulation of proteins in the mesangial matrix. Now once these proteins will start to accumulate in the mesangial matrix, they will cause the proliferation of the mesangial cells. So over there other mononuclear cells and even excessive formation of extracellular matrix, and eventually global sclerosis of the glomerulus will happen. Now with increasing reduction in the nephron mass and ongoing compensatory changes, a vicious cycle of continuing glomerulosclerosis will set in. And remember, most of the mediators of chronic inflammation and fibrosis, especially TGF beta, they play an important role of development in sclerosis, not only in the kidneys, throughout the body. TGF beta is also the hormone, the cytokine or this inflammatory mediator which is responsible for liver cirrhosis. Again a very important MCQ. So is this point very clear that how reduction in the glomerular mass or reduction in the kidney mass because of either a glomerular or non-glomerular condition will lead to focal segmental glomerulosclerosis? Everyone?
Yes, sir.
Okay. So this is the basic diagram which is also given in Robbins. So whenever there is a reduction in the renal mass, okay, ultimately there will be some hemodynamic changes leading to systemic hypertension. There will be intraglomerular hypertension. There will be glomerular hypertrophy, that is a compensatory glomerular hypertrophy. Okay, along with this compensatory glomerular hypertrophy, ultimately there will be endothelial and epithelial injury. Okay, intraglomerular coagulation will also start, and there is mesangial cell hyperplasia along with extracellular matrix deposition, ultimately leading to glomerulosclerosis. And because of this injury, there will also be, and because of effacement of the podocyte food process, it will ultimately cause proteinuria as well. Is this very clear how a reduction in the renal mass is a very important cause of FSGS? Okay, very clear. So we have discussed the inherited forms, we have discussed the idiopathic form, we have discussed secondary to renal ablation. Okay. Now if we look at the morphology, okay, if we look at the morphology by light microscopy, the focal and segmental lesions may involve only a minority of the glomerulus, because as we know it is a focal. So a few of the glomerulus might be involved, okay, and sometimes it might be missed under the biopsy because of insufficient number of glomerulus. Where in the glomerulus where there is a sclerosis, whatever capillary loops are there, they will undergo collapse completely. There will be increase in the matrix in that part, so that part will appear more pinkish in nature. and there will be segmental deposition of plasma proteins. That is, there will be proteins are seen how? What do we describe the protein deposition as? We call it as hyaline change. So a hyalinosis will be seen. Okay, and that hyalinosis might become so much pronounced that the glomerular capillaries might get occluded altogether. So if you see, look at, this is the light microscopic picture. If you look at the electron microscopy picture, both sclerotic, non-sclerotic areas will show diffuse effacement of the foot processes. Foot processes of what? Foot processes of what? Of visceral epithelial cell, called as the podocyte. And not only this, as I told you, because in the process there is also focal damage to the visceral epithelial cells and the GBM. So if you see, there will be focal detachment of the epithelial cells and breakdown of the underlying glomerular basement membrane, that is going to allow the plasma protein to travel into the mesengium, causing mesangial cell proliferation, inflammation, and along with that they will induce a sclerosis as well. If you look at the immunofluorescence, by immunofluorescence the IgM and C3 may be present in the sclerotic areas and or in the mesengium. So you might see IgM and complement products deposited in the sclerotic areas or in the mesangium. Now lipid droplets and foam cells are also present. Now why they are present, I have already discussed that point yesterday in nephrotic syndromes. I am not discussing again. So as the disease will progress, more number of glomerulus will become involved and sclerosis is going to spread within each of the glomerulus. So the change will now become global. Okay, so there will be global sclerosis of the glomerulus, total sclerosis. And along with that, not only that, the process will now start to involve the tubules. There will be tubular atrophy and there will be interstitial fibrosis as well. Now, a morphological variant of FSGS is also called as collapsing glomerulopathy. As you can understand from this term, the entire glomerulus is going to retract or collapse. Okay, they will retract or they will collapse. A characteristic feature is the proliferation and hypertrophy of glomerular visceral epithelial cells. So we will see over here in case of collapsing variety that there is a lot of proliferation and hypertrophy of the glomerular visceral epithelial cell. Now again, this can either be idiopathic or it can be seen secondary to certain drug diseases. Most characteristic lesion, secondary to HIV associated nephropathy. Now collapsing glomerulopathy is typically associated with prominent tubular atrophy, prominent interstitial inflammation, and has a very bad prognosis. So just remember this part about collapsing. So now in your exam, classically you will be given one diagram like this. So first thing that I am going to ask you, you tell me what is this? This is one glomerulus. Agreed or no? Yes?
Yes, sir.
This is another glomerulus. Okay.
Yes.
Now what I want to ask you in this particular diagram, can you see that one glomerulus is involved but not completely? A part of the glomerulus is involved. Yes or no?
Well,
So can we say that this is a segmental change?
yes.
And what I told you, focal glomerulosclerosis. So there is a protein deposition, along with that extracellular matrix production is there, which under the microscope is looking more pink in color. Yes or no? This is the focal segmental glomerulosclerosis lesion that we see. And the basic stain that we have done over here is the PAS stain, which is highlighting them as well. The segmental sclerosis involving the upper half of both the glomerulus as we see. So I hope in the exam, if such a diagram comes, you will be easily able to recognize this. Not very difficult. Each and individual terms are also recognized. You tell me, what are these? What is this structure that we see? This is the kidney tubule. Okay, this is the kidney tubule that we are watching over here. Okay. Now this is another diagram over here that I want to show you. So again, can you appreciate over here? This is the part which is classically involved. Can you also see that some of the capillaries, they have collapsed? Okay, they are on the verge of collapsing. Yes. Can you see there's an excess amount of extracellular matrix deposition? Acha, also very important, if you see in the sclerotic area, small vacuoles are there, which are nothing but the lipid droplets in the sclerotic area. These are nothing but the deposition of lipids in the sclerotic area. So these are nothing but the lipid, okay, represented by small vacuoles, okay, in the sclerotic area. This is the area where there is a sclerosis, okay. Also, can you see over here, okay, can you see one area of hyalinosis? Okay, This is the area of halitosis as we can appreciate over here. Okay. The next important diagram, now over here this is a collapsing glomerulopathy. As we see, the glomerulus, a part of that has actually collapsed. If you see, they have actually collapsed over here, as we can appreciate. They have collapsed, means they have collapsed like this. So part of the glomerulus over here has collapsed. Okay. Now also remember that there is narrowing of the capillary lumen. So whatever capillary lumens, as we can appreciate in this collapsed part, is also narrowed down. Okay. So we cannot see the capillary loops very clearly. Okay. There is also proliferation of the visceral epithelial cell, not that much clear in this particular diagram, but it is there. Okay. Okay. And very important, you can see the intracellular, okay, protein absorption droplets in the visceral epithelial cells. So visceral epithelial cells, they are showing protein absorption droplets, as we can appreciate over here. Just remember these points at least. If you don't remember the diagram, that's also enough. Okay. Now, very important thing, there is a little tendency for spontaneous remission in case of idiopathic FSGS, and the responses to corticosteroid is not consistent, it is variable. Children having FSGS, they have a better prognosis as compared to adult, and the progression to renal failure is variable. Around 20% patients, they have an unusually rapid course. They will develop collapsing glomerulonephropathy and they will die with a massive proteinuria ending in renal failure within 2 years. The factors associated with rapid progression includes the degree of proteinuria, the degree of insufficiency at diagnosis, the histological subtype. For example, as we had seen, the collapsing variant has an unfavorable course. There is a tip variant also which has a good prognosis. Recurrences is occurring in 25 to 50% patients of FSGS who has received allografts. Okay. Is this point very clear about FSGS? Any doubts are there with regards to FSGS? Focal segmental glomerulosclerosis. Anyone is having any kind of doubt? Yes. So you will be able to answer all the questions. Okay. Especially the pathogenesis is very, very important. Now we are going to start another very important type of glomerulopathy, that is membranoproliferative glomerulonephritis. Now, Mpgn is best considered a pattern of immune mediated injury rather than a specific disease. So it is more of an immune mediated type of injury. Now there are two types. One is the type 1, jahan par you will see the deposition of immune complex, okay, containing the immunoglobulin IgG and complement. But there is also a second variety over here which is called as dense deposit disease. Okay, these are called as dense deposit disease, in which activation of the complement appears to be the most important factor, and basically the C3 group is mainly involved, that is the alternate pathway activation is the most important, and these come under the heading of C3 glomerulopathy. So C3 glomerulopathy is equivalent to type 2 Mpgn. We will call it as type 2 Mpgn, or we call it as dense deposit disease. So Mpgn is characterized by alterations of the GBM. There is an accumulation of mesangial matrix, proliferation of the glomerular cells, there will be leukocytic infiltration and presence of deposits in the mesangial regions and glomerular capillary wall. Now the deposits are basically made up of immune complex in type 1, and in type 2 there is some deposit, but it is of an unknown material. You don't know what is it made up of. In type 1, the deposits are made up of immune complexes, wherein the antibody, antigen antibody complex will be there. The antibodies and complements will also be deposited over there. In type 2, remember one thing, very important point. In type 1, I told you the deposit is comprising of immune complex. In type 2, the deposit is made up of unknown material. So remember, there is a deposit which we do not know what it is. But also in type 2, only in the glomerular basement membrane you will see the C3 deposit. You will not see the C3 deposit in the dense deposit or the unknown material deposit in type 2. So remember this point very carefully. C3, although present in the type 2 Mpgn, but they are present only on the GBM. In the electron dense deposits, you will not see any known material. It is of unknown material that has not been seen. Okay. This is very important point. Okay. So because on the basis of this point only, because in type 1 you will just see immune complex deposition, but in type 2 that immune complex cannot be demonstrated. Now in both the types you will see that there is a proliferation in the mesengium. So there will be infiltration by the mononuclear cells, there will be proliferation of the mesangial cells, there will be excessive deposition of extracellular matrix in the mesengium as well. Okay, remember. And very important, they might also involve the glomerular capillaries. So we also call it as a mesengiocapillary variety of glomerulonephritis. Now Mpgn is accounting for up to 10% cases of nephrotic syndrome in children and young adults. Okay, 10% cases of nephrotic syndrome in children and young adults, they are because of Mpgn. So predominantly FSGS as well as Mpgn, they are what? They are what? What are they? They are nephrotic syndrome only if they are asked in the exam. Okay, but as you will see, they are not a clear cut. Some patients again might have hematuria, some patient again might have proteinuria in the non-nephrotic range. Okay, very clear to everyone? Yes? Is this point very clear to everyone? Okay.
Yes, sir.
Okay. Now Mpgn is increasingly recognized to be associated with other systemic disorders and non-etiologic agents. For example, just like we have primary and secondary and everything, over here also we are having secondary Mpgn. Okay, just remember this, other systemic disorder known. So this is called as secondary Mpgn. Okay, and those where only the kidney is involved and we do not know about what is this, so we call it as the primary Mpgn. Okay. Is my voice clear, audible to everyone?
Yes, sir.
Okay. In most cases of type 1 Mpgn, if you see, there is evidence of immune complex in the glomerulus. I told you. So in type 1, immune complex will be there and both the classical and the alternative complement pathways will be involved. Very important. Okay, the antigens which are involved in the idiopathic Mpgn, we do not know where they are coming from, but it is hypothesized that these are secondary to hepatitis viruses. They might behave as an antigen. Okay, so they might form as a planted antigen and they might lead to this immune complex formation in type 1 Mpgn. Now in case of your the morphology, if you look at the morphology of Mpgn, now as you see it's a membranoproliferative. So we have already seen one proliferative glomerulonephropathy. Where have we seen? Where have we seen one more proliferative glomerulopathy? Yes?
Yes, sir.
Very good. Over there also what did we see? The glomerulus has become large and hypercellular. So over here also we can see the same thing. The hypercellularity is produced why? Over there also the same cause, here also the same cause. Because it is a proliferative glomerulopathy, proliferative glomerulonephritis. So over here it is produced by both the proliferation of cells in the mesengium as well as the endocapillary proliferation as well. The same thing as we have seen, and there is an infiltration of leukocytes also. Now the glomerulus, they have a lobular appearance. Why? Because of this proliferating mesangial cells and increased mesangial matrix, they gain a lobular characteristic appearance. These are under the light microscopy that we are talking about. Very importantly, when you do the PAS staining, the glomerular basement membrane seems to be duplicated like this. देखो इस तरह से दिखेगा. Somewhat like this if you see, not completely. At some areas you will see there is a doubling of the layer like this. Then at other areas it will be like this. So there is a doubling or duplication of the basement membrane, which is also called as basement membrane splitting. Usually it results because of synthesis of new basement membrane synthesis in response to the subendothelial deposits of the immune complex. So in case of Mpgn, actually type 1, if you see, there is subendothelial deposit, and this subendothelial deposits actually causes the basement membrane splitting. Now remember the one important point of difference between type 1 and type 2. In type 1 Mpgn, what you will see that the deposition is subendothelial, and the GBM splitting will be there. Now in type 2 what happens, the deposition is intramembranous. That actually causes splitting in nature of the GBM. So in both the types, in the characteristic feature in type 1 and 2 is your splitting of the basement membrane or doubling of the basement membrane. Though the type of deposit is different. In the first case it is subendothelial location, and the second case it is intramembranous in location. I will show you with the help of diagram, don't worry. So in between the duplicated basement membrane, there is interposition or inclusion of the cellular elements. Okay. Now such interposition, it gives an appearance of a split basement membrane. Split basement membrane, very important feature over here. Type 1 Mpgn, if you see, there is discrete subendothelial electron dense deposit. The location is subendothelial. Whereas in case of type 2 Mpgn, which is called as a dense deposit disease, over there is an intraepithelial. Okay. By immunofluorescence, as it is basically which kind of disorder? Is it basically what you can say? It is a immune complex disease. So again you will see IgG and C3 deposition in a granular pattern. And very important, the classical pathway complement products, that is C1q and C4 deposition, will be present in case of type 1, but this will not be present in case of type 2, which will only have C3 deposition. Is this concept and point of difference very clear? I will show you when I will discuss dense deposit disease. I will discuss this point. Clinical features, if you see, most of the patients with primary Mpgn, they present in adolescence or they present in young adults with nephrotic syndrome, and there is a nephritic component also manifested by hematuria or more insidiously as a mild proteinuria. So now you remember my point. Mpgn, if you have to choose between nephrotic and nephritic, which syndrome it is, you will choose which one? You will choose nephrotic syndrome only. Okay. But for example, if you have an option both of them, then you will choose both of them. Okay. Now, few remissions can occur spontaneously in either type, and the disease follows a slowly progressive but unremitting course. Some patients can develop numerous crescents, and they might present as an RPGN also. Around 50% patients are developing CRF within 10 years. Now secondary membranoproliferative is nothing but the type 1 only, but where a particular cause is known. For example, they will occur secondary to chronic immune complex disorder like SLE, hepatitis, Hep B, cryoglobulinemia, or some cause has been identified, or because of alpha-1 antitrypsin deficiency, or because of any underlying malignant disease. For example, CLL. Okay, so basically secondary membranoproliferative glomerulonephritis, all signs symptoms will be same as type 1. They are more common in adults and they are secondary to certain causes. Okay. So with this, I am just showing you, this is the light microscopic appearance. Can you see the mesangial proliferation has taken the form of lobules? Yes, can everyone appreciate this? Yes, so this is the lobular architecture in case of type 1 Mpgn. Type 1 Mpgn. They show mesangial cell proliferation with increased mesangial matrix. Okay, there is a increased lobular architecture with infiltration of the leukocytes, endocapillary proliferation, mesangial cell proliferation, extracellular matrix deposition. Now if you look over here, very important, this is the type 1 and this is the type 2. Now both of them, this is basically an immune complex disease. Okay, immune complex disease. Over here, if you look at the deposits, the electron dense deposits, these are the electron dense deposits. Can everyone appreciate? So these are subendothelial in location. That means just beneath the endothelium they are present. Okay, very important. These are electron dense deposit, but they are present in the subendothelial location. Now they are incorporated into the glomerular capillary wall. Okay, now what has happened that they have duplicated. For example, if you see, if you look at the glomerular basement membrane, a part of the GBM is here, a part of the GBM very small is here. So in between two, they have interposed, but basically they are subendothelial in location. Very important. And some of the deposits, they are also seen in the mesangial region. This is the classical mesangial region over here, which is showing the deposits. Okay. Now this is the type 1 Mpgn. Now in the type 2 Mpgn, that is the dense deposit disease, the deposits, if you compare over here, the deposits are not very uniformly present. But over here in case of type 2, the deposits are present. Very importantly, they are dense, homogeneous deposit. They are more dense and they are homogeneous deposits. They are occurring within the glomerular basement membrane and thus they are splitting them. Okay, very important. So the glomerular basement membrane over here is also split. So you can see a part of GBM here, a part of GBM here, as if they have been split. And very important, the deposition is homogeneous if you compare it with the type 2 variety. Is this chart very clear to everyone? Yes? Very clear to everyone? Okay. Now we will read about the, yes, any doubt?
Yes, sir. One doubt, sir.
Yes, tell me.
Here that splitting is occurring is main they are just synthesis of the new membrane.
Actually, the splitting is occurring in response to the deposition. Okay, so the deposition, if you see, whenever there's a subendothelial deposition also, they are causing splitting of the basement membrane. And within the splitting, you can also see the deposits. Along with that, some inflammatory cells you can also see within the deposits. Is this clear now?
Yes.
But remember, if you have to choose the location for type 1, it will be subendothelial deposit, and for type 2, they are within the basement membrane, intramembranous. Okay, I will just show you. Now the dense deposit disease. Now most patients with dense deposit disease, previously called as type 2 Mpgn, they have major abnormality as excessive activation of the alternate complement pathway, not the classical, wherein the C3 complements are basically activated. So these patients will use up C3 far more than the C1 and C4. So these patients consistently have a decreased amount of serum C3, but the levels of C1, C4 is normal. That shows that the classical pathway is not involved. They also have decreased levels of factor B as well as properdin and the components which are components of the alternate complement pathway. So C3, factor B, properdin, all these three, they are important components of the alternate pathway. So these three are decreased. The glomerulus, they contains deposits of C3 and properdin, but there is no IgG present. Okay, so remember the deposits, the glomerular, especially the GBM, the glomerular basement membrane is containing the deposits of C3 and properdin, but there is no IgG inside of that. The alternate complement pathway C3, remember, is directly cleaved to C3b. Just remember this over here. There is a generation of C3bb, the alternate pathway C3 convert. It is an enzyme actually. C3bb is the C3 convertase. Now normally remember this C3 convertase is this enzyme which is required for the activation of the alternate pathway. In normal individuals, remember, they are labile. That means they will be destroyed. Okay. But what happens that in cases of Mpgn2, there is a particular factor called as C3 nephritic factor present in the Mpgn2 patients or in dense deposit disease patient, which is providing protection to this C3 convertase, and it is not allowing this C3 convertase to become inactivate. So this C3 convertase becomes active and it is constantly activating the alternate pathway of complement activation. So there is a persistent C3 activation and there is a hypocomplementemia. There is also a decreased C3 synthesis by the liver in this situation. Okay, so profound decrease in C3 levels are seen in such patients. Now mutations and components of the alternate pathway, that is factor H, which leads to unhindered or excessive activation of the complement pathway, has also been associated with the dense deposit disease. So if you see, look over here, okay, basically, for example, any of these factors are present, they are basically activating this C3 convertase. So normally this C3 convertase should be inhibited, okay, in our body. But basically in over here, what is happening, because of the presence of this factor, okay, that is the C3NEF, that is C3 nephritic factor, because of the presence of this basic nephritic factor over here, okay, this is being stabilized, and this is being stabilized by this factor which is basically present in patients of dense deposit disease. They are stabilizing this factor, and as a result, this is causing activation of the C3, and thus the alternate pathway is getting stimulated, and thus there is excessive stimulation of the alternate pathway that is seen. So very importantly, by electron microscopy, what you can appreciate over here, if you see basically in this, you will see that there is a permeation of the lamina densa layer of the GBM, which is the central layer, by a ribbon like homogeneous electron dense material of unknown nature. See over here, whatever term I have said you right now. So inside the glomerular basement membrane, there is a permeation into the lamina densa layer by a ribbon like electron dense, uniform, homogeneous, okay, substance of unknown nature. We don't know what is it made up. It is not an immune complex deposition. So the nature of this deposition is not known. By immunofluorescence, we can demonstrate the C3 deposition as a linear focus, but only in the glomerular basement membrane. So this is present only in the GBM. They are not present inside that electron dense deposit. So it is not present within the electron dense deposit. Very important point. C3 is also present within the mesengium, And remember, immunoglobulin is not present, it is absent. Okay, so immunoglobulin along with C1, C4 when present, then they are justifying the presence of immune complex. But because there is absence of IgG, so basically we are not seeing that immune complex is there. So these are actually components of the classical pathway. So because these substances are not present in dense deposit disease, so we can say that the classical pathway of complement activation is not there. Again, this is mainly present in case of children and young adults, just like the Mpgn type 2, and the presentation of this is mainly nephritic syndrome. Okay, remember, with hematuria, along with that nephrotic syndrome component might be there. So Mpgn type 1 is mainly called as Mpgn type 1 now. So whenever you are using the term Mpgn, mostly it is used for type 1. And type 2 Mpgn before was used, the term was used type 2, but now they are called as dense deposit disease, and mainly they are presenting with nephritic syndrome. The prognosis is quite poor, with one half of the patients progressing to end stage renal disease. There is a high incidence of recurrence in transplant recipients. Dense deposit occur in 90% of such patients who are having recurrence. Now this is another diagram over here wherein I wanted to show you. Now it will become very clear. This is the type 1 Mpgn. So what did I tell you? In type 1, what will be there? There will be subendothelial deposits. So on the inner side, what is this? This is the endothelium. Let me show you with another yellow. So this is your endothelium over here, E. Uski just beneath you are having this subendothelial, but this subendothelial is also encroaching and permeating inside the glomerular basement membrane. So it is also causing some kind of a splitting. Understand this point very clearly. So this is the very important. And this deposit, what is it? What nature is of this deposit? It is an immune complex deposit it is. Okay, it is an immune complex deposit, very important. And it is having both the components of alternate as well as the classical. So classical means C1, C4 is also there, along with IgG will also be present. Crystal clear? On the other hand, we are having Mpgn type 2. Over here, the deposit is classically intramembranous, and they are continuous. They are regular ribbon-like. They are not patchy, as we can appreciate over here. So, but remember, the splitting of the basement membrane will be seen in both. So the term splitting of basement membrane is a feature which is seen in both types. Okay, if you have to choose the answer. With this we have completed. Now we will read about the IgA nephropathy. We will read and understand about what is your IgA nephropathy ke baare mein we will understand. So IgA nephropathy, if you see, it is characterized by the presence of prominent IgA deposits where in the mesangial region, and the patient has characteristic recurrent hematuria. It is the most common type of glomerulonephritis worldwide. So someone was asking me, sir, IgA nephropathy will come under nephrotic syndrome. So have you got your answer now? Yes? The answer will be glomerulonephritis. IgA nephropathy is the most common type of glomerulonephritis worldwide. It can be suspected, remember, by light microscopic examination, by only the detection. Okay, but remember one thing, the diagnosis can be suspected by light microscopy, but the diagnosis will be made only when we can demonstrate IgA deposition in the mesangial region. Mild proteinuria is usually present, and the nephrotic syndrome may occasionally develop. So this is just occasional in nature. It will not always develop. Rarely the patients can have RPGN as well. So remember, IgA nephropathy, typically it occurs as an isolated disease, but similar deposits can be present in systemic disorders in children like Henoch-Schönlein purpura, which has many overlapping features with IgA nephropathy. Now in addition, secondary IgA nephropathy might develop in patients with liver as well as intestinal disease as well. If you look at the pathogenesis over here, very, very important. In one line, if I have to say the pathogenesis, is that this IgA or this immunoglobulin IgA, they are having an abnormal form of glycosylation, because of which they are getting trapped and deposit in the kidney. So IgG, which is the main immunoglobulin which are present in the mucosal secretions, they are present in the plasma at a very low concentration, mostly in the monomeric form they are present. Okay, the polymeric form of IgA, they are not present, they are catabolized in the liver. So in patients with IgA nephropathy, the level of polymeric variety of IgA is increased. So normally हमारे body में कौन सा type होता है? Monomeric variety. But in case of IgA nephropathy patient, the polymeric variety is increased. Okay, but this amount is not sufficient to cause this disease. Then what is the cause? So a clue. So basic important thing is that this polymeric immunoglobulin A, they have an aberrant form of glycosylation. So it is believed what is happening over here, there is an acquired or hereditary defect in the normal formation or attachment of galactose residues to the IgA molecule. So if you just remember the point that there is an aberrant glycosylation in case of your in case of this patients, the IgA or the immunoglobulin A is polymeric in nature and they have aberrant glycosylation. So this aberrant glycosylated IgA has a tendency to deposit inside the glomerulus, and they will elicit an autoimmune response and they will form immune complex in the circulation with the IgG autoantibodies, okay, which are directed against this IgA molecule. So understand what is happening over here. There is immune complex formation with regards to the abnormal IgA, that is abnormally glycosylated or glycosylated IgA deposited over there, and these immune antibodies that are formed, IgG autoantibodies, they go and they deposit in the mesangium, which is containing the abnormal IgA. Out of the different kinds of immunoglobulin A, immunoglobulin A1 is deposited in the mesangium with subsequent formation. Now what will happen? These mesangial deposits, whenever they will deposit, they will activate the mesangium. So once the mesangium is activated, there will be proliferation of the mesangial cells. They will increase the ECM deposit, plus they will recruit more inflammatory cells. So there will be inflammation along with glomerular injury. Now the deposited IgA and IgA containing immune complex will also activate the complement via the alternate pathway, and over here also the presence of C3 will be there, and absence of C1, Q and C4 in the glomerulus is also typical of this disorder. So we can also say that this has some features of C3 glomerulopathy, just like your dense deposit disease. Okay. Okay. Now you can also read this point. Okay. Now IgA nephropathy occurs with increased frequency in individuals who are having gluten enteropathy, that is celiac disease, in whom the intestinal mucosal defects are well defined, or in patients with liver disease with defective hepatobiliary clearance of the IgA complex. Okay. So on histological examination, what you have to see over here, the lesions, they vary considerably. The glomerulus may be normal, or they may show mesangial widening. Along with that, endocapillary proliferation will be there. So you all know these points, we have read about it. Okay, so there is a mesangioproliferative glomerulitis like picture, segmental proliferation confined to some glomerulus, so focal changes might be there, and sometimes crescentic glomerulonephritis might also occur. So there is a lot of variation in IgA nephropathy. Okay, so you can also see infiltration by leukocytes. The mesangial widening is because of the cell proliferation along with increased matrix formation and deposition. Now healing of these lesions can lead to secondary focal segmental glomerulosclerosis. So I already told you, if you remember, that Fsgs can also occur because of an active necrotizing lesion. Over here, do you remember this point? Over here I had shown you that this can also occur over here as secondary to certain previously active necrotizing lesion, that is IgA nephropathy. So Fsgs can also result secondary to IgA nephropathy. So here I have already mentioned and I have discussed this point in detail as well. Okay, dense. Okay, so as you can see, this is an immune complex disorder. So the characteristic immunofluorescent picture is a mesangial deposition of immunoglobulin A. Along with that, the components of the alternate pathway C3 and properdin is also deposited. Early complement components are absent. That means the classical complement pathway component C1, C4 is absent. Electron microscopy will show classical deposition of electron dense deposits predominantly in the mesangium. Okay, so you can appreciate over here there is a mesangial proliferation. Can you see why we are saying this is a mesangial? Because around there are capillaries. So surrounding the capillaries you have the mesangial deposition, as we can appreciate, an increase in mesangial matrix. If you see by immunofluorescence, you have to demonstrate the deposition of IgA in the mesangial region by immunofluorescence. Only when such deposition is shown, then only we can label it as IgA nephropathy. Okay. Now one type of hereditary. Now we are going to read about one example of hereditary nephritis, that is the ALPORTS syndrome. So remember that hereditary nephritis, they are a group of familial renal disease associated with mutations in the collagen genes, okay, which are manifesting as a primary with the glomerular injury. They happen. Now there are two very important points. One is the ALPORTS syndrome, another one is your basement membrane nephropathy, the most common cause of which is benign familial hematuria. So the one that we will discuss is the ALPORTS syndrome, which is very important from an exam point of view. So it is caused because of mutation in the type 4 collagen, resulting in hematuria with progressive CRF, accompanied by nerve deafness along with various eye disorders including lens dislocation, posterior cataract and corneal dystrophy. It is an X-linked trait. All of these are MCQs. Okay, in approximately 85% cases they are X-linked traits, so they will be more expressed in case of males, while females typically just will present with hematuria. Around 90% of affected males will have end-stage renal disease before 40 years of age. Now autosomal recessive and autosomal dominant pedigrees will also there, but they are forming a minority amount. So if in the option you have X-linked, autosomal recessive and autosomal dominant, and the fourth option is all the above, so what are you going to choose as the answer? The answer will be all the above. If you have to choose any one, then you will choose X-linked trait. Now the pathogenesis, if you see, as I already told you, there are mutation in one of the several genes coding for the subunit of type 4 collagen. So type 4 collagen also has various subunits. Okay, so one of the subunits of type 4 collagen is involved. More than 500 mutations are there resulting in disease have been identified, all of which are interfering with the assembly of type 4 collagen, and this collagen is important in the glomerular basement membrane, the lens of the eyes as well as in the cochlea. That is why the syndrome is characterized by various eye disorders like lens dislocation, cataract, corneal dystrophy and by nerve deafness as well. Okay. Now because the type 4 collagen chains are encoded in the autosomes and the X chromosome, the inheritance pattern can be both autosomal as well as X-linked. Now genetic analysis is showing that patients with X-linked disease, the large deletions of collagen type 4 in alpha 5 chain is seen, and patients with such deletions are associated with end-stage renal disease at an earlier age. Now fully developed ALPORT syndrome, if you see, they have characteristic electron microscopic finding. What is that we will see? Very important, the GBM over here, if you see, there are areas which becomes thick, there are areas which become thin, thick, thin, like that. So GBM shows irregular focus of thickening alternating with areas which are thinned out, and there is pronounced splitting and lamination of lamina densa. But over here the distinctive appearance that is called as a basket weave appearance. Okay, similar alterations also seen in the tubular basement membrane also. If you do the immunohistochemistry, okay, you will see absent or borderline basement membrane lesions because antibodies to alpha 3, 4, 5 collagen fail to stain both the glomerular as well as tubular basement membrane in the classic X-linked form. So there will be no staining with the alpha 3, 4, 5 collagen. There is absence of alpha 5 staining even in the skin biopsy. So this is showing that the alpha 3, 4 and 5 subunits of the type 4 collagen is absent. So as the disease will progress, ultimately the patient will develop Fsgs, okay? Fsgs. Initially the changes will be segmental, later on the entire glomerulus will be involved, so that global is there. Most common presenting sign is gross or microscopic hematuria. So just like your previous IgA nephropathy, this is also having a nephrotic syndrome presentation. They will have renal cast in the urine. Proteinuria might develop later, and rarely nephrotic syndrome they might have. Symptoms will appear in early age between 5 to 20 years, and the onset of overt renal failure will occur between 20 to 50 years of age.